Good evening. Welcome back to the next edition of my Ask Me Anything. Hope you guys had a great Memorial Day last weekend. I was traveling to Florida and enjoying some sunshine and visiting some family. So hope you guys had a good one as well. See some great questions as always. So, I'm a board certified cardiologist. My job is to help you reduce your risk of having a heart attack and stroke. And it mainly comes down to three things. Can you optimize your glycocalyx and keep your nitric oxide levels high? Can you keep your oxidative stress and inflammation low? And can you modulate your lipoproteins when needed? So we'll jump into the questions. So the first question, what are my thoughts on buying deuterium-depleted water? I have some. I don't recommend most patients consider it unless they have a cancer or autoimmune condition, or if you're a high-level athlete, maybe you'll notice a performance benefit, but most people, they're not going to necessarily need it. It is not very inexpensive depending on what your use case is. I mean, it's probably going to be a $10 to $20 a day habit if you're going to really continually use deuterium depletion. And it really depends on how long the treatment course is going to be. Is it the rest of your life, or do you have a goal that you're trying to treat with? So do have some patients that are using it, but I don't think it's for the majority of people. Is taking creatine and or collagen supplement good for the heart? Creatine, likely. I mean, creatine helps support muscle function. So the heart is a muscle. So usually it's 5 grams of creatine, and it's built up over time. No real downsides to taking creatine at that dose. Collagen, probably not as beneficial for the heart. Good for skin, hair, and nails. But the heart, it's much more about the glycocalyx, and collagen shouldn't really have much effect on the glycocalyx. Does testosterone play a role in arterial health and heart health? Absolutely. If you're hypogonadism, low testosterone for a man, you have increased risk of atherosclerosis and dying from vascular disease. There's a Goldilocks zone of testosterone. You do want to replete any deficiencies to relieve any symptoms. The symptoms of fatigue, insulin resistance, difficulty gaining mass, libido issues, depression. May be beneficial to replace testosterone to a level that makes those symptoms go away, but supraphysiologic doses aren't necessarily more beneficial. You get some downside effects, if your estrogen level's too high or your dihydrotestosterone level's too high. So large sweet spot. So you need to work with somebody who is well skilled in using testosterone replacement therapy wisely, and not blocking estrogen indiscriminately. There's a questionnaire called the ADAM questionnaire, the aging deficiency, or I should say the androgen deficiency in the aging male. 10-point questionnaire. The more questions you answer yes to, the more likely testosterone is causing those symptoms. And it was the recent Traverse trial that had shown that, and this was topical testosterone replacement therapy was not associated with increased cardiovascular risk. And now the FDA is taking out the black box warning for testosterone, which honestly should have never been there in the first place. Some flawed studies from the VA that had contributed to that finding. Next question, can one reduce a high CT coronary calcium score with supplements? The short answer is yes, but it always depends on what's causing the high calcium score. So back to the original points that I mentioned, you need to keep your glycocalyx healthy and nitric oxide levels optimal. That prevents further plaque buildup in the arteries. Keep oxidative stress and inflammation low. You can do Boston Heart Lab, Cleveland Heart Labs, Quest, LabCorp Labs to figure that out. And then use whatever tool, lifestyle, medications, or supplements to generally keep your lipoproteins in the 20th percentile. So for most people, if you have plaque in the arteries, you should probably be shooting for an APOB under 70, but primary optimal under 60. And definitely have seen calcium scores improving, or at least not progressing. If you don't do anything, generally the calcium score does increase about 20 to 25% a year. If it's only increasing 5% a year, you're kind of winning. You need to look at CT angiogram, particularly like the Clearly analysis, AI analysis, that would tell you if the soft plaque is regressing. And I've definitely seen soft plaque regressing. In my own case, it regressed at least 6% in a 2-year period, and I don't have any calcium. What can I do about a CAC score of 428 with no symptoms? Good stress test. So a CT coronary calcium score of 428 would be considered high risk. Generally about a 15% risk of having a heart attack in the next 10 years if you don't do something about it. you have a calcium score over 1,000, that's very high risk, approximately a 1 in 3 chance of having a heart attack in the next 10 years unless you did something about it. Having no symptoms is often common. If they went so far as to do a stress test, that means you likely don't have ischemia or lack of blood flow to the heart tissue, but your risk of heart attack was not assessed with the stress test. It's more about the plaque stability. You can look at some biomarkers that gives you an idea if the plaque stable or unstable, but they clearly really looks at how much soft plaque you got, and it's the soft plaque that tends to rupture more and cause the heart attacks. It's not the hard plaques. The hard plaques may cause symptoms of chest pain because of a fixed obstruction, but if you pass the stress test, probably don't have a 70 or 80% blockage in one of your coronary arteries. So you have to do kind of the deep dive. Why did you develop endothelial dysfunction? The underlying of the arteries got damaged somehow, and then cholesterol particles were retained in the arteries, inflammation occurred, plaque built up. So you got to figure out what's driving it. There's maybe up to 300-400 different risk factors for vascular disease: high blood pressure, high cholesterol, high insulin, smoking, obesity. Those are the top 5, but you got to go looking for many more things. But that's what we do at Apollo Cardiology. That's where our expertise is lying in, is finding people's risk factors that they weren't aware of and help modulate those through lifestyle interventions, supplements when needed, and optimizing medications based off of pharmacogenomics. Question: why brain strokes happen in patients who have cholesterol LDL 108 in their 40s and active? High blood pressure is generally the main reason why people have small vessel disease. It's not always lipids related. Lipoprotein A could be present, insulin resistance. Again, back to the endothelial dysfunction. It starts there. Figure out what's damaging the lining of the arteries and try to repair that. And you really reduce the risk that further blood vessel damage occurs. It's good that somebody was looking for it. You have 60,000 miles of blood vessels. If you're developing it in one territory, there's always a risk that you develop it in other territories. So it's happening in the brain. There's more risk it's happening in the heart, happening in the sexual organs, happening in the lower extremities. So you need to go looking for it. And then the last question that was pre-submitted was, can I share the live so you can watch later? Absolutely. All these lives are saved. They're in my archives on Instagram. And then they're also on my YouTube channel, which is drtwyman.tv. Sometimes take a week or two for these Instagram ones to make it over there because I got to manually download them, upload them, and then get AI to transcribe them. But there's up to about 5 years of archives up on my YouTube channel if you're interested in looking for some of the older episodes. But every Monday night, 6 p.m. Central Time, we do it again live. All right. Well, let's see. Any questions coming into the comments? Does the level of risk for cardiovascular disease correspond with a given level of LPLA? The short answer is the higher the levels of LPA, the higher the cardiovascular risk. So everybody makes a certain level of lipoprotein A, but 20% of the population or so genetically has higher levels. And it is almost linear. The more LPA you have, the more atherosclerotic risk you have. But not everybody with high LPA has plaque. And so this is where test don't guess philosophy comes in. So look at the arteries, endothelial health. That's what the EndoPAT test. Look at vascular, reactivity markers like pulse wave, which tells you how stiff your arteries are. Quick surrogate for home is, what is your blood pressure? Is it normal? Ideally less than 120/80. And then for LPLA, the 3 big labs that I look at routinely is, the LP-PLA2 activity. It's an inflammatory marker. If it's high, then LPA is more likely damaging the arteries. If oxidized phospholipid APOB, which is a specialty lab that only Boston Heart Lab does, if it's high, LPA is carrying around those damaged phospholipids. And then if interleukin-6 is elevated, that means there's arterial inflammation. So I always look at those 3. If they're all in the green zone, you can have high serum levels of LPA, and it may not be doing anything to your arteries. If those things are in the red zone, you may have something to worry about, and you're going to be more aggressive treating all the other risk factors that you can address. So I see lots of patients with LPA. I've been routinely checking patients since at least 2013, so for the past 12 years. So I have hundreds of patients who have had high levels of LPLA. Doesn't mean it's a death sentence. Doesn't mean you necessarily are going to have a calcium score over 1,000 or high risk clearly, but you do got to get assessed. So it's one risk factor out of the 300-400 that potentially can damage the arteries. All right. So maybe short and sweet. So I may not go the full 30 minutes, obviously. Yeah, I got through all the questions ahead of time, and I don't see any other ones coming in through the comments. So if any other questions, you want to pop them in here, I'll happily answer them. While I'm waiting for those to come in, I will kind of drop a little bit of news. Is that, it's been a couple years since I've done a retreat with patients from Apollo Cardiology. We're getting the kind of information all put together for a retreat in the fall. It'll be in October in Arizona. Be on the lookout for further details. That'll be near Halloween. Probably a 2 or 3 day type of event. It's at a place where one of my favorite places to go, where there'll be hiking, and there's a lot of wellness opportunities. So if you're interested in learning more about, my concepts of, how to optimize circadian biology, if you're interested in thinking about how to optimize mitochondrial function, definitely can talk about all these vascular, things that we talk about here. And also then you can see, what I might talk about for nutrition or exercise or stress management or, sleep optimization. Now, this is going to be a good place for that. So if you're interested, stay tuned. If you're really interested, send me a direct message, or if you're already a patient of Apollo, be on the lookout. There will be an email coming out in the next week explaining some more details. But if you're really interested, you can drop me a DM on Instagram, and I'll let you guys know about it when it goes more formal. And then one question while it popped up here was, what causes tachycardia? Wouldn't be able to answer this with just one prompt here. But tachycardia, by definition, is a heart rate over 100 beats per minute. Is it symptomatic or asymptomatic? Symptomatic, okay, is it all the time? Come and go? Are you having episodes where you're actually passing out, near passing out, chest pain, shortness of breath? Okay, that's more worrisome. Need a monitor, probably need an echocardiogram to assess, do you have a structurally normal heart? Blood work, make sure you don't have an overactive thyroid, make sure you don't have anemia or some type of electrolyte maladies. So a lot of things can drive tachycardia, but requires a kind of a workup biochemically and oftentimes some imaging. And where are these glasses from? These particular ones, these are the EMR Tech glasses. I have multiple of the brand models. I tend to use a lot of the Wolverines. Those are the gold frame ones. But these ones came out last year. They're all clear. So these are ones I like to wear on hot days and when I don't want to wear the gold biohacker ones. Very good question. What test should everyone have after the age of 50 to know if they're heading in the wrong direction? How much time you got? So if you could only do one, and you've not previously had a heart attack, stroke, stents, or bypass, start with a CT coronary calcium score, low dose radiation, CT scan, about the same amount of radiation as a chest x-ray or a long haul flight, in an airplane, so not a lot of radiation. But tells you, do you have any hard calcified plaques in your arteries? Calcium is supposed to be in your bones and teeth, not in your arteries. So if your calcium score is 0, you're low risk. If your score is anything but 0, you got to figure out why it's not. If you live long enough, almost everybody's calcium score test becomes positive. You just want to be as late as possible. I've unfortunately seen some people under 40 have very high risk findings. So I used to say 40 was the cutoff. I would say now probably 35 years old and above. If you've not previously had the test, consider it. After you know that part of information, then you can decide what else you might need to do. Blood pressure should be normal. You can check that at home. 115/75 would be optimal without meds. And then biomarker-wise, 3 big buckets. What are the ones that affect nitric oxide? So uric acid, homocysteine, ADMA. What affects the inflammatory cascade? Check hsCRP, probably LP-PLA2 activity. And the lipoproteins. Check out PLA if you've not had it previously checked, because 20% of the population has high levels. And then if you only looked at one thing, probably look at APOB or apolipoprotein B. Start there, and then you know what you're dealing with. So it says, do carotid artery scan results correspond with atherosclerosis? So I'll give it to you where, it depends which imaging version you had. So the carotid duplex ultrasound is looking at the speed of the blood flowing through the arteries. It's mainly there to look at, the amount of stenosis or blockage you may have. It will comment if it, assesses how much blockage you have, and if you do have any blockage, you have atherosclerosis. Another scan that we do in the office is called a carotid intimal medial thickness scan, or CIMT for short. Uses ultrasound technology as well, but it's mainly looking at how thick the intimal layer is. And that's the layer underneath the endothelium. The endothelium is what decides basically what stays in the blood and what gets access to the arterial wall. If the intima is thick, you have inflammation in the artery and you're more prone to developing plaque, but you don't necessarily always have plaque with a thick intima. But if you have evidence of plaque, you'll see it on a CIMT, and it's graded as less than 30%, 30 to 50%, or greater than 50%. So oftentimes you can find atherosclerosis on a carotid scan, and if you have plaque there, there's about an 80% correlation you'll have plaque in your coronary arteries. So if you find it in one place, go looking in the other arteries as well. Question about sleep apnea says, what do I recommend for sleep apnea? Well, first is diagnose it. So that's a good thing that you're asking about it. Highly prevalent disorder. If you're not sleeping well, if you don't feel well rested the next day, if your spouse says you snore or stop breathing, you got to get screened for sleep apnea. And determine if you have central or obstructive sleep apnea. If it's central, you're pretty much going to require the help of a sleep specialist, and you're going to be on probably CPAP or BiPAP to be able to treat that. If it's obstructive, sometimes weight loss helps. Mandibular positioning devices can help. Mouth tape can help. There's certain straws that can improve the oral pharynx's ability not to collapse at night. So lots of things can be done for it. We refer a lot of patients out at Apollo Cardiology locally to Clayton Sleep Center. And if they're more remote patients, often we recommend Empower Sleep. They have kind of a sleep coaching system that will figure out why people have apnea and give them some options on how best to treat it. All right, so maybe short and sweet. So I'll let you guys get back to your evening. I'm going to go for a nice long walk. I'm trying to keep up to at least 10,000 steps a day. Significantly dropped off after coming back from Japan, where I was averaging highly over 20,000 every day. But when I hit at least my 10,000, and I'll be back next Monday, 6 p.m. Central Time, to answer your questions, help you guys not have heart attacks and strokes, and live your best lives. So have a great week, and stay tuned for the information about the fall retreat with the Apollo Cardiology.